Respiratory system inspection. Introduction. The setting for the chest examination must be environmentally comfortable for both clinician and patient. Technique. The pulmonary examination consists of inspection, palpation, percussion, and auscultation. Inspection is an active process. It is done with the eyes and the intellect. It begins with the initial greeting and continues uninterruptedly during the entire data collection process. Even as the first serious question of the fully dressed patient is asked, the inspection begins through active observation. What to observe during inspection? Skin integrity, shape and symmetry of chest, respiratory rate and rhythm, movement of chest, check spine and scapula. Procedure. Introduce yourself and confirm the patient's identity. Ask for the patient's consent before beginning. Begin inspecting the patient in a seated position, unsupported if possible, and undressed to the waist. If the patient is too ill to sit upright, support assistance may be necessary. Work from the upper chest downward, comparing one side to the other. Inspect the skin of the chest wall. Check for cyanosis or pallor, scars, wounds, bruises, lesions, nodules, or superficial venous patterns. Observe for red or reddish-blue coloration, excoriation, or exudate. Next, assess the shape and symmetry of the chest. A normal chest is bilaterally symmetrical. Observe the thoracic cage for any deformities such as pectus excavatum, pectus carinatum, scoliosis, kyphosis, chest deformity, surgical or traumatic scars, thoracoplasty, or gynecomastia. Listen to the anterior, lateral, and posterior thorax. Record the respiratory rate. This is not required if done with vital signs measurement. The normal respiratory rate of a relaxed adult patient is 14 to 16 breaths per minute. Assess the rhythm of respiration. Normally, respirations are regular and quiet and not too shallow nor too deep. The inspiratory phase is half as long as the expiratory phase. Observe the patient as he or she breathes both quietly and deeply. Look at the symmetry of the chest wall movement, costal versus abdominal breathing, the use of accessory muscles, bulging or retraction of the intercostal spaces, and pulsations or heaving. Examine the back of the patient as well. Inspect the spinal column alignment and curvature. Observe the scapulae to look for any unequal scapular height. Respiratory system, palpation. Introduction. The patient's history determines the scope and intensity of the chest examination. When the history elicits suspicion of the presence of a chest problem, the physical examination of the thorax must be expanded beyond a minimal screening examination to determine the nature of the problem so that a diagnosis can be made. Technique. Palpation is used both as a screening technique and as a means to confirm a specific diagnosis. What to observe while palpating? Any swelling, any pain or tenderness, position of trachea, chest expansion, chest symmetry, tactile vocal fremitus. Procedure. Ask the patient to sit in an upright position. Note the temperature, moistness, and turgor. Examine for any edema. Rule out any pulsations, bulging, masses, depressions, or unusual movement. Check the tracheal position by palpating between the heads of the two clavicle. A slight deviation of trachea to the right is normal in healthy people. Trachea is displaced to the affected side in conditions such as fibrosis or collapse. Palpate over the sternum. Look for any structural deformities such as pigeon chest or funnel chest. Feel for chest expansion. Grip method. Face the patient before proceeding. Place both hands firmly on the anterior chest wall on the lower rib cage, with the thumbs meeting in the midline of the patient's chest. The thumbs must not touch the chest. Ask the patient to take a deep breath in and note the distance as both the thumbs move apart during inspiration. Then ask the patient to breathe out and note the distance during expiration. The movement must be equal on both sides. Repeat these steps on the back of the patient. The affected side is prominent and chest expansion is reduced in pneumothorax, pleural effusion and emphysema. The affected side is shrunken with reduced expansion in fibrosis and collapse. To find out the chest symmetry, you must measure the chest expansion and hemithorax using a measuring tape. Take the tape and encircle the patient's chest around the level of nipple. Take measurements at the end of deep inspiration and expiration. Normal chest expansion in a healthy young man is 5 to 8 centimeters. Chest expansion in emphysema patients may be less than 1 centimeter. Measure the right hemithorax by encircling the tape from the vertebral spine to the midpoint of the sternum. Ask the patient to take a deep breath and then exhale. Measure the right and left hemithorax during inspiration and expiration. Asymmetrical chest expansion can be seen in pneumothorax, pleural effusion, fibrosis, or extensive consolidation or collapse. Palpate for right supraclavicular lymph nodes by asking the patient to move the head slightly to the right so that the skin relaxes. Palpate deeply just above the clavicle to assess the supraclavicular lymph nodes. Do the same on the left side. Palpable nodes could suggest the presence of infection or metastatic disease. Check for tactile vocal fremitus by placing the ulnar edge of your hand on the chest. Now ask the patient to say 99. Check the fremitus in the upper, middle and lower areas of both lungs on the front and back side. Vocal fremitus is decreased in pleural effusion, pneumothorax and emphysema. It is increased in consolidation and neoplasm. Respiratory system. Percussion. Technique. The purpose of percussion is to determine if the area under the percussed finger is air-filled, that is, sounding resonant like a drum, fluid-filled, that is a dull sound, or solid, a flat sound. To make this interpretation, it is important not only to listen for the sound produced, but also to feel the intensity and frequency of vibrations produced by this maneuver. What to observe during percussion? Dull note, resonant note, diaphragmatic excursion. Procedure. Make sure your palm is warm before percussing any patient. Ask the patient to lie supine. Place the left middle finger, fleximeter finger, on the area to be percussed. The back of its middle phalanx is then struck with the tip of the right middle finger, percussing finger. Make sure that the percussing movement originates at the wrist and not at the elbow. Percuss over each intercostal space on the anterior, lateral and posterior chest wall in such a way that the long axis of the percussed finger is roughly parallel to the ribs. Compare one side to the other. When percussing over the chest and back, move back and forth across the thorax in a systematic fashion, comparing one side of the body to the other. There are two sounds to listen for while percussing. Resonant sound, dull sound. Resonant sounds will be heard during percussion over the lungs till you reach the diaphragm. If you hear dullness over the lungs during percussion, this could possibly suspect the presence of a mass or consolidation. At the end, conclude this exam by assessing the diaphragmatic excursion. Percussion. Ask the patient to sit upright with the back exposed and ask to take a deep breath and hold it. Then begin percussing at the base of the right scapula and move downward towards the patient's diaphragm. When you detect a change from resonance to dullness, you will have found your first anatomic landmark. Tell your patient to breathe and place a mark at this site before continuing to the next step. Now, ask your patient to exhale as much as possible and hold it. This time, begin percussing at your first landmark and move upward on the posterior thorax towards the scapula. When you notice a change from dullness to resonance, you will have found the second landmark. Place a mark at this site. Repeat this technique on the other side of the patient's posterior thorax so that you can compare measurements on the right and left sides. Once you obtain your two landmarks, measure the distance from one line to the other to determine diaphragmatic excursion. Normal excursion distance is 3 to 5 centimeters. Respiratory system, auscultation. Technique. What to observe during auscultation: breath sounds, vesicular, broncho-vesicular or bronchial, vocal resonance, bronchophony, whispering pectoriloquy, egophony, added sounds, pleural rub, wheezes or crackles. Procedure. Introduce yourself and confirm the patient's identity. Explain what is going to take place and ask for consent. Auscultation of the chest is generally done with the stethoscope diaphragm and is ideally performed in a quiet room with the patient either sitting or standing. Listen to the anterior, lateral and posterior thorax. Comparing one side to the other is a helpful maneuver to identify the patient's normal. Position the patient's arms over the head to listen to the lateral sides. When the posterior thorax is examined, the patient's arms should be crossed anteriorly to move the scapulus laterally as much as possible. Assess the intensity, normal, increased or decreased, and quality, vesicular, bronchial or broncho-vesicular of the breath sounds. Vesicular breath sounds are heard on the periphery. Bronchial breath sounds are heard normally over the trachea, the upper sternum and paraspinal areas of the upper thoracic vertebrae. They are often loud and high-pitched. Vesicular breath sounds. Broncho-vesicular breath sounds. Bronchial breath sounds. Confirmation of the presence of bronchial breath sounds can be obtained by listening for egophony, E to A sound. This sound is elicited by asking the patient to say the letter E as one listens over the suspicious area with the stethoscope. When consolidation is present, the spoken E sound is audible as an A sound, similar to that produced by a bleating goat. Check the vocal resonance by asking the patient to say 99 while ausculting the upper, middle and lower areas of both lungs on the front and back side. When the sound appears to be near the earpiece of the stethoscope, known as bronchophony, suggests that the sound is traveling through a mass of fluid. Vocal resonance is decreased in pneumothorax and emphysema. It is increased in consolidation. Ask the patient to whisper 1, 2, 3 to assess for whispering Pectoriloquy. A clear and audible 1, 2, 3 could indicate a consolidation. There are 3 types of abnormal breath sounds that arise in the pleura and in the lung. Frequently, they are collectively referred to as adventitious breath sounds. Pleural rub. Wheezes. Crackles. Carefully examine the areas that revealed abnormal findings during palpation and percussion. In a dyspnea patient, it is best to auscultate the abnormal areas first, that is, the lung bases, in case the patient becomes fatigued during the examination. Physical findings must be interpreted in the light of all previously collected data. The general scheme is to develop a postulate and test it with further history, additional observations or maneuvers on physical examinations and laboratory tests.